Hello, and welcome to the Surgical Assistant Podcast, a podcast crafted by surgical assistants for surgical assistants, where professionalism meets passion. Hello, good evening, everybody, and welcome to another episode of the Surgical Assistant Podcast. My name is John, and as usual, I'm here with Kelly. Hi, Kelly.
Yep. Hey, how are you?
How you doing?
I'm good. Doing good. How
Great.
are you?
I am great, thank you. I thought for tonight's episode, we talk about positioning the surgical patient. And before we start, I just wanted to add a disclaimer here. We might mention some products by name, but we do not endorse or promote any specific product. We just simply throw the names out there because that's what everybody in the operating room community knows them as.
Mhm.
You find whatever product works for you and you use that. But just because we mention it on here by name, we do not endorse that, and nor are we telling you should use it. You do what you need to do for your institution. So
Mhm.
we'll get it started.
Right. And the principles are the same too, as far
Exactly.
as what we mentioned brand names or a name of something. Yeah, you're right. Doesn't mean anything. It just means that's what a lot of people know it by. It's commonly known and doesn't change the principle of what we're talking about tonight.
That's a great point. Yeah, a lot of places have maybe just improvised something, and then a company sees that and turns it into a permanent product, a
Mhm.
disposable product or non-disposable product, and everybody uses it. But I do feel it's necessary to call them by name. So maybe if you've never heard of it at your institution, it may switch a light bulb on and we go, hey, let's try that and see how it works,
Mhm.
or get a sample from the company and see how it works. So
Mhm.
anyway, so we're gonna, I guess, kick it off with some of the basics of positioning.
Right.
And like I was thinking, sounds kind of basic, but why would positioning be important in the surgical patient? Because we all go to sleep every night, and none of us wake up with a nerve palsy or a pressure ulcer. But the reason is, the patient is under anesthesia, which in the 1800s, Oliver Wendell Holmes coined the term anesthesia, which means without sensation or without feeling. So when we put the surgical patient to sleep, as you probably heard in other podcast episodes with anesthesia, they are unable to move or correct their position. But if you're on something uncomfortable while you're sleeping in a lateral position, unconsciously, your body will roll you over without you waking up. But the surgical patient can't do that. So if they're in a certain position for 5, 6, 7 hours, it could have some disastrous consequences. So that's why surgical positioning is paramount. And it's every member of the surgical team's responsibility to participate in positioning, and everyone should know the proper principles to position. But I believe ultimately it is anesthesia's responsibility. And I think after that, it will fall onto the surgeon and then the rest of the OR team. But so why is surgical positioning important? Well, we need access to the operative site, and anesthesia needs access to their endotracheal tube. There's physiological consequences of, doing anesthesia in certain positions, and ultimately patient protection. So for physiological effects, I mean, the patient's given a neuromuscular blockade. So initially when they go to sleep, they're given a muscle relaxer, whether that's depolarizing or non-depolarizing. And for a lot of the procedures, we don't want the patient moving reflexively. If you touch the endotracheal tube, they could buck, or we don't want them breathing against the machine because all that stuff could, influence the surgery, especially if it's a laparoscopic procedure. So the best way to do that is to, have them completely anesthetized and paralyzed so they can't move. And then they're not able to shift their positions and get a pressure ulcer. So it's up to us to protect the patient. So, Kelly, do you have anything to add on that you'd like to add?
Well, I do want to add, John, actually, the people that are most responsible for positioning and positioning injuries. So, of course, if we have the core team in the room and we're first assistant, so we want to assume that we're in the room. So you have the circulator, the first assistant, the CST or the scrub tech, and anesthesia in the room. And so we're all kind of taking part in positioning. Now, depending on the complex nature of the position that we're going into, that probably doesn't take all of us to be involved, but we do want to involve as many people as it takes, especially depending on the patient's weight, the patient's size, again, how complex the position is, how much moving and manipulating of that patient's body that we're going to have to do. I do want to point out that I always, when I'm positioning a patient, I always confer with anesthesia and let them have the final say. I was educated a few years ago that if a positioning injury, and you may or may not know this, and our audience may or may not know this, but if a positioning injury occurs, so I'm talking about an injury to the patient that occurs specifically because of positioning or an error in positioning or something that maybe somebody wasn't paying attention to and something's wrong, like, let's just say a nerve injury happens.
Mhm.
The in a in a legal situation, the anesthesia provider, the buck stops with them on that. So, that's truly important for us to realize that we do wanna loop the anesthesia provider in if they're not as engaged, they might be looking at other things, but always engage the anesthesia provider. And also, they have a different perspective than us, right? Just a different
Mhm.
physical perspective. They're standing at the head. Maybe they can see if something looks lopsided or something's not right, or they're checking the hands and the shoulders, especially the shoulders up, they can look at. So I just wanted to mention that we do, as a OR team, we're all involved in positioning that patient. Ultimately, anesthesia is gonna have the final say in that positioning because they're the ones that are held paramount accountable to any injuries that take place there.
Oh, thank you, Kelly. I
Mhm,
really appreciate you adding that, and our listeners may remember that because I believe you brought it up on a podcast, so that's great.
mhm.
But, repetition helps, that's how I
Ri
learned, so but I'm so
right,
glad you
right.
did that. And I do the same thing, I always confer once I'm done positioning a patient, I always confer with anesthesia and the
Mhm.
doctor. Although sometimes maybe the
Correct.
doctor's not available, they're in another room
Mhm,
finishing a procedure, but if it's the very first time, because as many of you know, as I mentioned before, I work as a locum, so it's my very first time working with that surgeon, I will have him confirm my positioning before we prep and drape, just because I want
mhm.
him to know that, you
Correct.
know, check everything, and if he's good with it, then they usually, that's enough, unless they're, a really particular surgeon and they don't want you to do it without them. Some surgeons are like that, don't position the patient until I come in the room, so
Mhm,
I always abide by that. So some of the considerations when we position patients, we want to be aware of because we always want to protect the security of the endotracheal tube. Obviously, anesthesia places that tube and they secure it, but I've seen tubes get pulled out accidentally. I'm sure you have too, Kelly. You've seen IV
mhm.
lines that accidentally get pulled out. While it's not disastrous, it's inopportune. So we want to limit any of that stuff. So we also want to have considerations for the IV lines and the IV tubing. If they're going to be in a certain position and those you don't want those IV tubing roller locks right up against the patient in any position because that can cause a pressure sore, or those little plastic occluding locks that are on there. I usually cut them off, but that's institution specific. We want to protect the connections to the anesthesia circuit. So we don't want that coming undone if we move the patient's head or for whatever reason. We always want to pad the bony prominences. We want to make sure the patient is safe and secure and they're not moving. So we typically use a security belt or a safety belt, and that could be any type of belt. Some are leather, some are disposable. Depends on the patient positioning. I may put multiple belts on the patient. I may put 2 or 3 belts depending on the size of the patient, the type of positioning. And then we always wanna make sure and we're cognizant of nerve plexuses because there are, nerves that can be stretched by positioning. We'll get into that when we talk about certain positions. You wanna protect neurovascular structures. We wanna protect the patient from pressure sores, and we also wanna protect their eyes because as we get into other positions, which I believe Kelly's gonna talk about prone, we'll talk about why it's so important to make sure that the eyes are not being compressed. And the other thing too is as the surgical team members, we wanna make sure we don't lean on the patient. Sometimes when we're standing in a position for a long time holding a retractor, it's just human nature that you wanna kinda offset that. And you may get tired or fatigued, so you may lean on the patient, lean on the patient's chest. I worked with an anesthesiologist when I was early on that could tell if anybody was leaning on the chest just by how the anesthesia monitor changed. And I've been caught a few times. He's like, "Hey, who's leaning on the chest?" And I'm like, "Oh, I'm sorry." Sometimes it's not possible to do that, but we never want to rest our weight on the patient, especially if we're doing a surgical procedure such as a direct anterior hip and you're the assistant on the other side holding retractors. You don't want to rest your weight on that leg because it's suspended and it's free, and you could hurt their knee if you put too much weight on. Sometimes they may have a total knee, so you're pressing on it. You don't want to hyperflex that joint. So we always want to be careful of that. And then when we use certain retractors for general surgery or neurosurgery, they get that attached to the bed that help us self-retaining retractors. We also want to make sure that there's clearance between those and the patient. If there isn't, then we want to make sure that we pad those. So anything you'd like to add to that, Kelly?
No, I think you covered it. Those are all great points and great reminders for people to think about. And if you're yeah, I mean, if you're new coming in and a lot of times as the scrub tech, if you've scrubbed for a while, a lot of times that's not your focus. and you're not close enough to the patient to have to worry about that. But if you're transitioning into a first assist
Mhm.
role, these are all things that you do need to be aware of and cognizant of for sure.
Oh, that's wonderful. Thank you. And, some of the things, and Kelly had mentioned some of them, some of the factors that influence the type of injuries are general anesthetic, obviously, prolonged surgical times. If the case is
Hmm.
going to be a long, long, long case, you want to make sure that you're extra doubly careful of stuff like that. I can't speak tonight, excuse me. Also, maybe a patient has certain metabolic conditions like diabetes, so they have reduced, blood flow or peripheral vascular disease. They have reduced blood flow to certain areas of the body, and maybe normal pressure on that might cause an injury where it wouldn't. And then, like Kelly, you had mentioned extremes of weight.
Hmm.
So I think from that we can go on to talking about our first position, which would be supine. Would you like to talk about that, Kelly?
Yeah, yeah, and this is, probably our most basic and maybe one of our most common positions is supine, which is the patient is on their back, but still so many factors come into play with this position. We have different variances of supine. So when we say supine, the patient's laid out on their back, legs out, arms out. The arms could be out on a supported on arm boards to the side, so they would be out at their side. Obviously, when we put the arms out, we want to secure them to the arm board because we don't want them falling off. A lot of times, even when upon induction, you'll notice when the patient is put to sleep, if that arm is not strapped to the board, the arm will fall. So I try to place that if they're gonna be supine, and really, even if they're not gonna be supine, John, but I'm gonna just interject this here just because it's coming into my mind, is when the patient's being induced for anesthesia, it is important to know those where those arms are, right? Because they can move. I mean, when they give that, short-acting paralytic for intubation, fasciculation happens, so those muscles are moving kind of on their own, and their arms will twitch, it'll cause some twitching, and some of those movements sometimes the patient reacts more briskly than other times, and we can see that arm fall off the arm board. Now, I have worked with OR team members that are really concerned about strapping the patient down while the patient's awake. A lot of times when I'm doing it, if I'm placing that strap lightly over the patient's arm, I will let them know that I am placing this over your arm lightly. This is to keep your arm from falling off. If you are uncomfortable or if you need your arm for anything, let me know. So I do communicate with the patient that some patients are like, do not strap me down. In that case, we want to make sure those arms are down by their side and just secure. Just be aware, tuck a blanket around it or something so those arms can't go flying and falling off. Because even that is an opportunity for injury to happen. If that arm were to go briskly back or fall to their, behind them, that could stress the shoulder. So I just wanted to mention that to keep that in mind for the phase of intubation and induction of anesthesia. But supine, yeah, so we know the arms are going to be out or they're going to be tucked. So it's going to depend on the procedure here. If arms are out, we're going to have them out at their sides. We do want to make sure that the shoulders aren't scrunched up. You want the shoulders down, away, no stress on them and out to the patient's side and secured. Of course, the safety belt is over the thighs. We do want to make sure that belt is not over the knees. We want it over the mid thigh area, not over the genitals. So, especially in a male, we need to be concerned about that. That safety strap doesn't need to be too high on the patient. So, generally, I'll feel for the patient's knee and place my hand right above their patella and kind of use that as a guide that that's where I want to put that strap. If you don't anticipate a lot of moving, tilting the bed here and there, that's really generally it for supine. Now, here's another thing about supine. Placing a
Mhm.
pillow under the knees is a great comfort measure for the patient when they're still aware and awake, but it also does really help when they're asleep. It creates less stress for the lower back. So their legs aren't straight out and creating some kind of stress on the lower back. So a pillow under the knees is good unless you are going to be doing a procedure. And, we've moved away from this with the advent of robotic surgeries. Um, and actually, in robotic surgery, you have to be concerned about it too. So if you think about a laparoscopic case, a lap chole, for instance, where that camera, you're operating towards the patient's head. I know a lot of times when I was driving the camera, or if I'm driving the camera in a laparoscopic case, if their knees are too propped up on that pillow, you're gonna hit the patient's knees depending on how big they are. So, that's just something to keep in mind as we're doing that. When you place that pillow under their knees, think to yourself, is this going to hinder anything that we're doing at the field? Is the bump in their legs or the raise of their thighs right there going to be in our way at all as we're doing this procedure? And especially if it's a robotic procedure, you want to think, are the arms of the robot going to be hitting their legs? So that's just something to consider with that. But generally speaking, a pillow under the knees is a good idea. Now, if the arms are going to be tucked, of course, we want to tuck them at their side, securely, firmly, but not too tight. Always, as John already mentioned, keeping in mind those IV lines, arterial lines, anything like that that we're going to be could possibly occlude or something like that. Please keep in mind that when we're doing tucking the arms by the side, that the palm of that hand is toward their thigh and that it's not too loose. So I see a lot of people, they're overly concerned that their arm is gonna be tucked too tightly, and they actually leave it too loose. So we definitely don't want it hanging off the side of the bed, where it's going to hit maybe the metal or heaven forbid, come out of the tuck while we're doing the surgery. Another principle to think about there with tucking the arms is that a lot of people want to put I call it an egg crate foam, the oval shaped egg crate foams to protect the ulnar nerve. That's all fine and good. But if that patient's habitus allows us to tuck those arms by their side and their arms are resting on the OR bed, there's
Mhm.
really no reason to take up space and room with those foam pads or anything else to protect the ulnar nerve. Um, I say that because I have seen people add the foam padding in, and as well when the arms are out, that they add that foam padding in. If you can imagine putting the foam pad under the elbow here, it's gonna hyperflex. If they don't need it, it's gonna hyperflex that arm. The same can happen in the tucked position. If you add foam where you don't need it, it could actually alter the natural anatomical way that we're positioning those arms down by their side with their palms facing in. Their if their hands are kind of loose out of the tuck, you always wanna make sure that that thumb is tucked in, and if you have to position their hand, that thumb is tucked comfortably in their palm and those fingers are coming down over like this, if you can do that. So, just some just some things there. Oh, another thing, John, if they are it's a very large patient and we're in
Mhm.
supine and we're tucking, if you don't have bed extenders, a lot of people don't have the bed extenders to make the bed wider, then you might wanna consider using the arm slides. Those I don't even know what they're called.
Mhm.
I just call them arm slides. They're cradles for the arm. They slide under the mattress, and their arms can kind of
Mhm.
stay in there if it's a really large patient. So you can tell lots of things to look at your patient and consider about the procedure. That supine is not just supine, right? There's a lot of things to consider
Mhm.
when you're looking at that. So a lot of things to think about. If it's going to be if I anticipate that it's going to be a longer procedure, I will pad the heels, or even better, I like the flat gel pads to rest their heels on. And I think that's it I can think of for that, for supine. I mean, there's all kinds of little caveats and niche situations where you may need to augment or add something in. Again, if it's a large patient with large legs, you're worried about those calves or legs not staying on the table. If you think we're going to have to airplane the table one way or the other, don't be afraid to throw a piece of tape on those lower legs, secure it to the bed, tape over, again, not too tight. You always wanna make sure that that circulation is clear. We're not cutting off anybody's circulation. Typically, there's a blanket under that tape, but that will at least keep those legs from falling off the side. I don't know about you, John, but I have had cases where we did not do that, and at the end of the case, we noticed that the patient's legs hanging off the
Mhm.
table, and that's a horrible feeling because the surgical drape is on the patient. Nobody knows how long it's been like that, and that's just a scary thing. We want to avoid that for sure. So that's all I can think of for supine. What about you? Do you have anything else
That's wonderful.
to
I
add?
love those extra caveats you had, and that's the one thing about this podcast on positioning is there is no one way of positioning that's right for every
Mhm.
patient, every surgery. So that's where the creativity for this job comes in. As long as you remember the basics and the theory behind it, then you'll never go wrong. To always
Right.
both, all the principles we had talked about. If you adhere to those, you can be creative. We always called those things arm sleds. That
Eds, that's
yeah.
it. Mhm, that's
And
it.
yeah, those are nice. Sometimes they're made of metal, sometimes they're made of plexiglass. I think the plexiglass ones can be a little thicker, but they're safer because they're not metal. But some of the things I was thinking about supine, it's one of the most common ones, like you mentioned, but it's one of the most sort of easily tolerated for the patient, not easily tolerated, but it's more tolerated than some of the other patients for the patient's physiology, except if they're a really large patient, then their abdominal contents can, kind of restrict their breathing a little bit. It has limited effects on their cardiovascular system, so that's one good thing. And it's most commonly used for head and neck procedures, abdominal procedures, orthopedic procedures. I mean, quite a bit of procedures are done in supine. So, and one thing that came to mind too is sometimes our elderly patients have really bad kyphosis. They look kind
Mm,
of like shrimped up and sometimes, or they have a bad scoliosis. And in that case, maybe adding a little hip flexion can be beneficial for that. Maybe putting something under their hips or under their back to support them.
mhm,
Some patients, like you mentioned, I love what you said about the arm straps because sometimes patients don't, you know, get, patients get severely claustrophobic and they don't want to be strapped down at all. And I won't strap them down. I'm not going to cause them any stress because that can affect their physiologic state and how they go to sleep. But like you said, when they get that short acting muscle relaxer and it causes the muscle fasciculations, if they have especially a lot of muscle mass, yeah, they can jerk off the table. I've seen that. So I'll put
mhm.
them on loosely. I'll say, hey, can you tolerate that? And I will literally put it on so loose that it really wouldn't, hold anything. And then as soon as they're unconscious, I'll tighten it down so it doesn't come off. But I think it could also be procedure specific. I think in C-sections, a lot of places don't like to tie the mother's arms down because they want them to be able to hold the baby once they, hand the baby off and the neonate team has a chance to check the baby out. Because the best place is in mom's arms, so they do that for that. But I think that's yeah. Oh, I love the other thing you brought up about sometimes not putting a patient on a pillow under the patient's knees during robotic procedures because you can get that collision with their leg.
Mhm.
And also, not to skip ahead to another position, but I think when it comes to laparoscopic or robotic positions where you're going to stand the patient up, maybe a robotic cholecystectomy or a laparoscopic cholecystectomy, and we put a footboard on the patient. I don't like to have a pillow under their knees
Yeah.
because I think that it makes it more easy for if you don't put the pad in the right or
Mhm.
the strap in the right place, they could collapse down under their own weight, and that's never good. Or they're gonna be pushing that strap is gonna create a lot of pressure on their leg during the procedure, so if it's gonna be a prolonged case, I don't want that happening, but you'll be surprised how many people don't realize that. They will just put, "Oh, here's a pillow, you feel comfortable," and then I'll take it out when they go to sleep, and they're like, "Oh, no, you have to leave that in." I'm like, "Not really," and then but everything is institution specific, and you do what's right for your practice and what's right for your patients according to your institution's guidelines, so that's what I'd have to say, so but that's really all I have to say about supine. Oh, nope,
Good.
I have to say one more thing about that.
Mhm.
I had it when I was in school, I had a hard time distinguishing between supine and prone. And then my teacher said, "Well, if the patient's on their spine, they'll be in supine." And it just kind of stuck in my head and I never
Oh, I
forgot it.
never heard that. That's
So,
good, yeah.
and then the one she used for prone is they'll be laying on their esophagus and their entrails, and prone has an E in it. But to me, it wasn't as, memorable as
Supine
the
has
other
an
one.
E
So
also.
I know, that's what I'm not even smart enough to realize that, but I just like the other one because it was more melodic and more
That's
poetic,
funny.
but, so
Yeah.
but that's it. Anything you wanna add to that before we move on to the next
Mm,
one?
no, I think that covers it, yeah.
Okay,
And
so
then
the next
next you're gonna talk about lithotomy, is that right? Is our
correct, I'm gonna
lithotomy
talk about
position,
lithotomy.
so, oh, this is
Yep.
a fun one.
Yes, and one of the positions where you have to be I mean, every position we have to be careful of the patient, but this has a little more a few more caveats to it. So, I mean, why would we put a patient in lithotomy? I mean, the one thing I love about medicine is it uses Greek as its root language, ancient Greek, which is, not a new language and still having new words added to it. So lithotomy, lith meaning stone, otomy meaning incision into. So they use it a lot for urologic procedures. And we could use it for GYN procedures, colorectal procedures, and genitourinary procedures when we need access to the patient's perineum or their genitals for whatever reason. So it does have some physiologic consequences, obviously. Also, depending on what position they're going to be in. Yes, they are lithotomy, but they could be in steep lithotomy for certain procedures, and then that could bring up some other physiologic issues and positioning issues, but we'll get into that when we talk about that in Trendelenberg, because I think the two go together tremendously and they dovetail perfectly. So, but a lot of things we want to be careful of, the complications we want to be aware of are nerve injuries. We can get femoral nerve injuries if the patient's not positioned correctly in the stirrups. So typically the hips are flexed and abducted. They're abducted into 30 to 40 degrees from midline. And you want the thigh to thigh angle of 170 degrees, but no more than 180 degrees. So you don't want to position them in too much flexion or too much abduction or adduction for that matter. And some of the injuries that can occur are femoral nerve injuries, which is why we want to keep the thighs at 90 degrees. You can get a peroneal nerve injury if their leg is up against, let's say, candy cane stirrups, which we don't use much anymore, but some doctors still like them and they're still used. So you want to make sure you swing the candy cane out so their knee and fibular head is not pushing up against it. Because if it's maybe for a vaginal hysterectomy, surgeon and the assistant may be between the legs and now you're pushing out against the candy cane. So a lot of places have those gel candy cane covers that protect that. I'll also put some padding on that too to protect the leg. You can get a lower limb compartment syndrome. You can have lower limb ischemia, especially if they're overflexed. You can get skin shearing, ulnar nerve damage. You can have an abduction injury. And the most important thing that I was taught with lithotomy is they are positioned correctly in the table where the U is on the table. Their bottom should be right on the edge of that. But that brings into the concern that when the foot of the bed goes down or the foot comes off, however the bed operates, you want to make sure that their fingers are padded. After
Right.
you've gone ahead and put them in position and make sure they're secured and use whatever positioning aids you need for that, take some extra foam and wrap it around their fingers so that it does not get caught in the hinges. I've never seen it, but I've heard of patients' fingers being amputated because of that. So yeah, I think really quickly, that's about what I have for lithotomy. I always usually make sure I put a strap across the patient's chest, but not too tight. Once I tighten it down, I look at anesthesia and I ask, are you okay? Is the airway pressure not too high? Because, you can constrict the chest down so much that you won't get any excursion in their tidal volumes will be affected. So that's about what I have for lithotomy. Can you think of anything that I might have forgotten?
Well, I would like to mention on the placement of the stirrups on the bed actually, which is not
Hmm.
positioning the patient per se, but it's important to mention because I've seen people place the
Excellent.
stirrup on the bed where the end of the stirrup is beyond the rail of the bed, if that makes sense, and we'll try to put a
Hmm.
picture, but I've seen the stirrup fall off under the weight of the patient's leg because it's not and also making sure that we're tightening down that stirrup
Hmm.
on the clamp, tightening down the clamp that the stirrup is sitting in, but also that the actual clamp with the stirrup in it is pushed far enough back that the no part of that stirrup where it's attached at the bed is coming past that railing that it's clamped to,
Hmm.
if that makes sense, not pushing forward. And we'll put pictures.
Hmm.
But listen, if you're new at this and you need that's just a very important. I mean, I have
Hmm.
seen stirrups fall off with the patient's leg in it, and that's a huge deal. Very high risk for injury there if that happens. I mean, don't want that to happen. So we'll put a picture. That's the only thing I can think of,
Yeah,
John. I think that you
that's
covered that
better.
really well.
It's kind of hard to describe, but you're right. We will put a picture up there because that's
Mhm,
so important. Because
mhm.
while also too, Kelly, you don't want it up too high on the bed either, because then you'll affect how
Correct.
their hip
Mhm.
flexes. And
That's
then
right.
here's where I don't know exactly how to word it, but on the stirrup itself, when you're talking about the angle of the patient's leg, that whole stirrup will slide up and down on that rail so you could account for
Mhm,
the patient's height. You also want to
mhm,
make sure that it's positioned correctly, that their foot is all the way down in the well of the leg holder, the Allen stirrup, for lack of a better term. Some people call them yellow fins. There's
Mhm.
blue fins. There's, ones that are bigger for the patient's weight for BMIs, higher than a certain number. You wanna make sure their foot is always in there and it's pushed up against the foot plate of the bed. You don't want it hyperextended or, just kinda hanging there without touching that. You don't no pressure on the perineal nerve, and then you wanna make sure that both of those little, I guess, clamps that you use to adjust the height are in the both symmetrical on both sides of the patient. So they're graded from 1 to 5, but positions 1 to 5. You wanna make sure that one's not in position 1 and the other leg's in position 5 because then they'll be
Right,
awkward. And
right.
you can have all kinds of you can get a femoral injury from that, and there was a case I was reading where a patient was in lithotomy and they had to move the leg down like you had mentioned, although this was in lithotomy for a robotic case, and they had it just hyperextended it too much, and they had a femoral nerve injury. They went to get out of bed and fell down because they could not use their
Mm.
leg. So while that resolved in a few days, still, we don't wanna cause patients any injury. So
Right. Well,
that's
I
what you
will
brought
add
up.
too that once the
Mhm,
patient is up in stirrups, I will get like, if I've put one of the legs up, I stand there at my leg, and a good way to tell if the leg is too rotated, externally rotated, because
mhm,
that's where we don't want that hip flexors, that you wanna look at the knee of the leg that you're the side that you're on.
yeah,
So look at that knee, and you wanna line it up with the opposite shoulder, if that makes sense. So where you're standing at that leg, if you'll just take and kinda eyeball the leg and how it's sitting in the stirrup, and look at their knee, and then line it up toward the opposite shoulder, and this one will be the same way. So, I'll double
mm,
check that, the nurse will double check it, let everybody in the room double check it for all I care. I'm
mhm,
gonna take care of my leg, and then I'm gonna go
mhm,
around just out of routine, I'm gonna go around to the other side, make sure that one's lined up too, and that way we're making sure that those knees aren't externally rotated,
mhm,
so there's no stress on that hip. And also, I do wanna mention that we wanna keep these patients in low lithotomy
mhm,
for as long as we can during the case. So, for instance, if we're doing a sigmoid colectomy, that those legs are gonna be down in low lithotomy, so it kinda just looks like they're sitting with their knees bent and their feet flat on the floor, in other words, like
mhm,
if they were laying on a floor with their knees bent and their feet flat. They're not gonna be up any higher than that until we need them to be up, so
mhm.
that's not gonna be so much the case during a GYN surgery on a female, but for those just keeping them low as long
Mhm.
as you can. Mhm.
That's a great point. I did forget to mention that, to line the leg and knee up with the contralateral shoulder. I meant to mention
Right.
that, and I agree with you. That's fantastic. Another thing I wanted to bring up, the last thing I'll bring up on lithotomy is this is why communication with anesthesia is key. If
Mhm.
if I'm down there closing anything or doing anything down there, I want to let them know my status because the last thing I want that patient to do is wake up in lithotomy because usually the foot of the bed is gone. Certain tables we use like a Trump table or other tables, the foot actually comes off the bed and we have to go get it and put it on in order to put the patient's legs back in lithotomy. Because remember, we're not putting them in lithotomy until they're asleep most of the time. So I'd say 9 times out of 10. So we always want to make sure that the patient's not waking up and then now they're trying to bring their legs up or move. And, they, like you said, if that lithotomy stirrup isn't tightened down, they could pull it right off the bed. And then now they're going to drop and their legs going to hyperextend. It could dislocate or break, God forbid. So,
Mhm.
yeah, I think that was a great point. So communication is key. So is, being speedy with the things you need to do so the patient does not wake up in that awkward position. So
Right.
unless there's anything else you want to add, Kelly, I'm gonna kick it back to you for the next position, which is prone.
Prone, I think this is probably the one anesthesia hate the most, right? It's just they don't like it. I mean, and you as you can imagine, when I first started in the OR, I used to think, how do they get patients on their stomach? I mean, like, how would you turn somebody over? Like, I had no idea, I couldn't imagine it, and of course, now I do, and then I remember thinking, "Well, how wait a minute, how does anesthesia manage an airway and do anesthesia and all the things they need to do with the patient literally upside down from them?" So, we have, if you've worked in this and you've seen it, it's that there is definitely a systematic approach to this, and there's tools and items that we use to help all of us. But prone is where you're going to need that extra turning help. I will say typically, I'm going to say always, unless it is a time where the patient's going to be semi awake for the procedure. The majority of time, 99% of the time, the patient's going to be put to sleep on their stretcher or the bed that they come in the operating room with. They're going to go ahead and be put to sleep. anesthetized, intubated, all that good stuff on their bed. And at that point, then we're going to get ready to move them over to the bed and flip them prone. So many different ways to do this. And you want to think of just standard, basic, body mechanics when you do this. It's best to move the patient all the way over to the side of their bed, closest to the operating room table. You want to make sure those heights are matching up. And yeah, it takes more personnel to go ahead and flip that patient over. Anesthesia is going to have the prone pillow ready, hopefully, and a lot of them will have that the mirror underneath the prone pillow so that they can look and see things on the patient's face that they need to see because the patient is faced away from them. So the prone pillow, and I'm gonna go ahead, John, and just act
Mhm.
like we're going prone on a regular OR bed. So we're not talking specifically here about the open Jackson or a Jackson table or anything like that. That's gonna be kind of a separate thing we talk about specific to those tables, those positioning tables. So for the prone case, I'm going to make sure before the patient ever even comes in the room, I'm going to make sure that I have several pillows, that I'm going to know what the doctor expects, how he wants the arms positioned. Of course, that's typically going to be on arm boards. They're going to be positioned a little bit differently because of where the patient's arms are going to be laying. We do want those straps for the arms because we want to secure those arms to the arm board. Again, a lot of times tape here is necessary also, again, depending on the patient's size. You want to think about having those gel pads under the patient's knees. I mean, if they're laying on their belly and we have to prop up the calves so that the toes are hanging free. So we want the bottom part of their leg, okay, between their knee and their ankle, we want that supported on pillows, but we don't want those toes rubbing against anything. So that's gonna bend our knees a little bit. So we do want those gel pads. I think those are the best thing. If you don't have gel pads, though, foam, egg crates would be fine to pad the knees with. Um, let's see. Again, depending on where we're operating, the safety strap will be on one part of the body or the other. So across the posterior thighs would be fine for that safety strap, or across the upper body would be fine, depending on what we're working on. Try to think of having something for the arms. We want to position those arm boards where the shoulders aren't hunched up because we don't want to mess with that brachial plexus. We want the shoulders to be in a relaxed position. Kind of just looks like the patient's chilling out up there with their arms kind of in front of them. But sometimes, John, and we might have mentioned this before too, if there's a big gap, like if it's a tiny, frail, older person or a very thin person or even a larger person, if you see any place up here in their axilla region, their chest region, anything that needs extra padding, you just kind of want to look at them from head to toe once you get them positioned. See if you need to kind of augment any areas there with padding and kind of fill in the blanks. Again, anesthesia is going to come in very helpful here because they're standing at the head and they can see the positions of those shoulders. They can kind of look at the patient's body alignment. You want to make sure that the hips aren't rotated one way or the other, that they're flat like they need to be. Again, you have to be creative with very large patients with a higher BMI. You kind of have to be more vigilant about looking at variances that you might have to do here and pull out everything you need to. You roll blankets, more pillows, tape, foam, all these things to help that patient be aligned and in that prone position. Again, depending on what the surgery is. John, can you think of anything else with prone?
I think you pretty much covered a lot of it. One of the things I would think of, one of the things that I always do for a prone patient, and this is why we say, we're talking about principles behind positioning. So
Mhm.
if you want to position a patient prone on an open Jackson, flat Jackson with a Wilson, or any kind of specific surgical table, you can do it as long as you adhere to these principles. Like you said, you want to make sure that you have those arms in what I call the Superman position, but they're actually 90 degrees, they're flexed 90 degrees or just a little bit less. I worked with one ortho spine surgeon that when he did his patients prone, he wanted them slightly less than 90 just because he had seen some litigation over things like that. And when it comes to strapping the patient, I always overstrap. I will, depending on obviously if it's a prone jackknife position for a hemorrhoid, I won't strap across the buttocks. But if it's anywhere else on the body we're operating on, I'll put a strap across the buttocks and one across the chest just to make sure. Some of the complications that can happen from a prone position is blindness. I mean, that's the biggest one. And that is just, from excessive pressure on their eyeballs during surgery. So that's why there's specific equipment that anesthesia will use for that. Like you mentioned, those prone pillows, because there's two types of positions you can have their head in. You can have it turned to the side, which again, you want to be careful of that. That's usually more for awake patients who are having some type of MAC procedure in a prone
Mhm.
position, because if you overturn their head, you can end up with a brachial plexus injury very easily. Or you have them in the neutral position, in which case we'll use some type of prone pillow or positioning device. And they have names. I can't remember them off the top of my head. Prone View, I think, is one of them by Mizzou. It's got a mirror, so anesthesia can look at the mirror and see that the patient's eyes are free. A lot of them will have these little masks that look like swimmer's goggles that adhere to their face, that have a plastic protective cup over both eye lenses, so there is no pressure on their eyeballs themselves. And then a lot of anesthetists and anesthesiologists will put ointment in their eyes, obviously, because when you're asleep, you can't blink, or they will tape their eyes shut. And that's so that their eye doesn't dry out, or they end up with a corneal abrasion, because we don't want that to happen either.
Well, I
And then again,
forgot. I completely spaced, John, and forgot one of the
space.
most important things on this one is part of that equipment that I'm or positioning aids that I'm bringing in the room
Mhm.
are the gel rolls for the chest. That's huge. You don't want the chest. So
Oh,
you're
true.
going to prop the patient up off the bed, right? Because
Hmm.
we don't want them laying just flat on the bed. That's going to
Hmm.
impede breathing. It's going to impede that inspiration and how their chest moves with breathing. So of course we want to prop them up on those gel rolls. So gel rolls are one of the basic, really important things that you need to bring in the room with all those pillows and the other
Hmm.
things that I mentioned. And the gel rolls, we have the big fat gel rolls and we have the little skinny gel rolls. I uh, definitely use these based on the patient's size. If you have a large patient or listen, a large breasted female, you definitely want to get the larger gel rolls to really lift that chest up off the bed because we don't want all that pressure laying on the chest when
Hmm.
they're laying on their stomach. So, gosh, that's huge. I
Hmm.
completely spaced on that, but that's very basic. That's something that we're going to wanna do. I have actually gotten to some interesting discussions, John, with my circulators where I've had times where they did not wanna use the large gel rolls. They wanted to use those
Hmm.
tiny ones, and if you're going to
Hmm.
err on one side or the other, what do you think it would be? Like, for most people, the large ones are going to be the most adequate, I think the most correct thing. At the
Hmm.
end of the day, we all want to look we wanna bring that anesthesia provider's opinion in for sure and ask before we ever flip the patient over, we wanna make sure. Now, what are some principles we need to think of with the positioning of those gel rolls? I try to get the bottom of the gel roll lined up with their anterior superior iliac spine because that's what the support on the patient's body we want that kind of supported on that gel roll. That's gonna be kind of the what's lifting the patient. With the top part of the gel roll that's up here, with a female, you wanna position the breast. We don't want the breasts being compressed against the gel roll. We want to kind of position the breast where the nipple areola area is in between the gel rolls. So again, we don't want that nipple being compressed or any breast tissue being compressed. So you're kind of positioning the breast where they're going between the gel rolls. So then in that case, the gel roll will be kind of up here on the breastbone and the ribs and just supporting that patient's weight, lifting them off of the table. Does that sound right, John?
Yep, exactly right. That's what I make sure of that. But it's so key. I love the point that you brought up. You have to have the right size roll for the right size patient. Some frail
Mhm.
90-pound elderly woman, she'd be fine with the smaller gel rolls probably, but like you, I agree. I'd always err on the side of caution, because you want that gap, you want that space, because
Right.
you want that belly hanging free, so there's no compression on it, which will increase abdominal pressure. It'll increase venous pressure. It'll limit, excuse me, limit venous return to the heart, which will decrease preload and cardiac output. You also want to make sure that they're supported, like you said, from the iliac crest all the way to the clavicle, and then that the breasts are inside in that void. That's what I always do. I always check the patient. And now I guess we should both mention that the arms can be out in what I call the Superman position. Like I said, less than 90 degrees or 90 degrees, and each shoulder blade even. I tend to look at the shoulder blades to make sure one's not propped up more than the other one. And also, sometimes they could be taped by their side. Excuse me, not taped, but secured by their side with a draw
Mhm.
sheet, and then again, use padding as needed for that. I like to make sure that their legs are, like you said, flexed and everything is padded. And then the other thing I'll do, if it's a male, I'll check to make sure the genitalia are hanging
Right.
free. And it's more important when we're talking about specific OR tables, more so the Jackson tables for spine procedures. If it's a long procedure and they're going to have a Foley, I want to make sure that that Foley is out of the way and not hanging down, because I've seen the Foley get caught by the C-arm coming in and actually pulled out of the patient. So not a good day. So I
Mhm.
usually make sure that that's secured along the rail of the bed, but in a way that it runs down so it'll drain. But we can get that more specific on another episode when we talk about, procedure specific equipment.
Mhm,
But
and I'm glad you did mention about the male genitalia. I didn't mean to leave the men
Mhm.
out of that. We do wanna check the penis and the scrotum both. We wanna make sure that nothing's being compressed. I mean, listen, guys, this is real life. This is what we're
Yeah.
dealing with. We're dealing with naked, nude, vulnerable patients, and we have
Mhm.
got to be their advocate. We've got to
We are
watch
their
out for
advocate.
them, and it's
Exactly.
all these little tiny things, these little details that you've got to pay attention to, and I
Mhm.
don't care if there's 3 people that check the genitals or the
Mhm.
breasts. Have at it. I want that to be
Right.
safe, right? And we
Mhm.
wanna make sure if they've got a Foley and there's no tension on that Foley that we're not
Mhm.
pulling it. Right, exactly. So, definitely you wanna adjust the penis and the scrotum as we need to. I mean, they're laying on their stomach. I mean, when you lay on your stomach, everything's compressed and tight, and if how long are they gonna be there? So, it's up to us to protect the patient on this, and everybody needs to have eyes on everything and make sure everything. I love it when a team comes together, John, and
Mhm.
everybody, we're asking each other, "Have you checked this? Have you checked this? Yep, this is free." And we're really communicating in this scenario. We're communicating with each
Mhm.
other and kind of going over the checklist from the toes to the head and back down again, making sure that everything's safe and secure and that patient is protected at all costs. Yeah.
That's wonderful. I love the way you brought that up too. That's what I have in my head. I have a mental checklist. And if you're new and just learning this stuff, write it down so you don't forget it. But that's what I do. Once I think everything's fine with positioning before they go ahead and prep, I run through that checklist in my mind, head to toe. Is
Mhm.
everything padded? Everything okay? Fully, boys are okay, this, that. It's also important to make sure, like you mentioned earlier, to have enough people to properly roll these patients. And there's several ways to do it. Sometimes I like, depending on what type of bed we're using or chest rolls, I like to have them roll the patient into my arms, and then
Mhm.
position the patient onto those gel chest rolls. And again, like I said in the beginning, this is just a way to do it. We're not endorsing any specific product, because I am sure there are as many products out there for positioning a patient in prone as there are patients, honestly. So some places don't even have gel rolls, so they roll up blankets and use that, which is perfectly fine. Blankets are
Mhm.
soft, they have
Mhm.
compression they give, they're not super hard. So you can roll up blankets, just make sure they're big enough to have that excursion for the chest, and so their abdomen will hang free. So yeah, that's about it. But the don't get hung up on the actual item, get hung up on the technique and the principle behind it. Because if you know
Mhm.
the principle, then you own it, and you could improvise to make it work as long as you adhere to those principles.
Right.
So I think
Yeah.
you brought up a great point.
All right, cool. So we are moving right along here, and we're going to go into another common one is Berg or Trendelenberg position. John, you're going to talk about that for us and tell us a little bit about what that is.
Ah, yes. Trendelenberg is named after Dr. Trendelenberg, or as a lot of doctors call it, head downenberg. I've heard a lot of doctors call it that. But it's basically supine with a head down, classically at 45 degrees, but it could be in any angle. And this comes into play in certain colorectal procedures when we need to see, or GYN procedures, really when we need to see deep in the pelvis. We need to put that patient in a steep Trendelenberg, so all of their abdominal abdominal contents fall away, and we can have unfettered access to that surgical site. But it also brings into a lot of physiologic issues with the patient, especially if they're an obese patient. I just to touch briefly on the physiologic effects. Initially, you get increased cardiac output for up to about 10 minutes because, gravity is helping all that blood return to the heart, but then it's got to pump against gravity back out to the extremities and back. So it does drop after about 10 minutes. It decreases the functional residual capacity of the lungs because all of those abdominal contents are now pushing against the diaphragm. And then the ventilator has to work harder to maintain the tidal volumes. In fact, if a patient is too obese, a lot of times we can't be in the amount of Trendelenberg the surgeon would like because they're not breathing enough, and it's detrimental to the patient. It will also increase intracranial pressure and intraocular pressure. So this is another reason why I say it's paramount that every assistant read the H&P. Does the patient have a ventricular peritoneal shunt? Did they have normal pressure hydrocephalus as a child or something? All those stuff comes into account, and it makes a big difference. If they're in that position too long, you can get swelling of the face and tongue and the larynx, which makes for a big deal in the airway when you're trying to wake them up. You get higher airway pressures, like I mentioned, when they're in that position. Also, you have an increased chance of aspiration and regurgitation. If so, read the H&P. Do they have a history of GERD? Are they on proton pump inhibitors? That's going to make an influence in that. So there's a lot of things to consider, especially, and this is where I'm going to have to just mention a few specific positioning aids, because I've seen it happen when a patient has gone from supine to really steep Trendelenberg, and they've slid down so far that anesthesia is holding the patient's head off of the bed because they didn't use any kind of positioning. I relieved on a case and none of that was taken into account. And the longer the case went, the more the patient slipped. And they happen to also be in lithotomy at the same time too. So now what is that doing? It's straightening and changing the angle of their legs. Not good. Not good at all, especially if you have some kind of uterine manipulator in. Now the patient's up too far and you can't manipulate it the way you want to. But that is the type of situation where you want to immediately flatten the patient out and secure them. So that's why I think a lot of these positioning aids are so important. I mean, they have ones, I guess I can go into the names of them, but there's the pink pad system that has a pink pad that goes on top of the bed. It secures to the bed. It is basically like that memory foam stuff. And the patient, you don't put a sheet on top of it, but you have a little draw sheet that you put right over the patient's sacrum that you use to tuck the arms with later. But that system can or cannot come with the actual non-fabric sheet. It's not made of any linen. It's made of like a material that doesn't slip against the pad itself, and it helps you to wrap the arms. They also comes with what we call tacos, which are these big square arm pads you actually wrap around the arm, and then you secure them with that sheet that I mentioned. And the reason is you don't want that patient to slip. Like I said, they could slip off the bed, or if they even don't move that much, it could shear the different skin layers. Depending on how heavy the patient is, you have the subcutaneous, shearing against the skin, and that can cause problems later on for the patient, which, we definitely don't want. There's one called the vac pack, I think it's called. And what that does is it actually attaches to the patient, and it's got these little plastic balls in it, like a beanbag chair used to have. And then you can mount that up around the patient's shoulders and different parts to give it support. And then you suck all the air out of it and it becomes rigid. But then again, when you use something like that, you want to make sure that the patient's well padded, because you'll mount it up under their shoulders, which is another consideration we want to remember, is that we don't want to use shoulder braces in patients like that, because that could cause a brachial plexus injury. You can have pads that just kind of support the weight and keep it from, moving when you move them into that position. But we want to use those certain positioning aids for steep Trendelenberg. So maybe you can add some other products that you remember, Kelly, but I'm blanking on them by name. I'm not endorsing any one of them. I'm just saying these are what I've seen, and they work well because they're very specific. In some places I've been, they don't have any of that stuff. So what I'll take is that egg crate foam and just cut a square piece big enough for their torso to set it on them, and I'll put it directly on the table. And then I'll put the draw sheet over it long enough so that we can wrap the arms and tuck them. But that is enough friction with them just against that foam and that little draw sheet just under their sacrum. You don't want it too high. You don't want it covering too much of the patient, because then it defeats the purpose. and then from there we can secure the arms. So it'll keep the patient from slipping when you go into a steep Trendelenberg for whatever type of position that you want to use. So is there
Right.
anything you'd like to add to that, Kelly, or anything I forgot
Yeah.
about
I don't know the names of the
Trendelenberg?
positioning of the positioning packs either, but, I've seen the different the pink pad system
Mhm,
that obviously we use a lot with robotic, but you're gonna use that if the case is laparoscopic. If the patient
mhm,
needs to go in a steep Trendelenberg, you wanna use
mhm,
something that's gonna hinder them from slipping and moving. I've seen that blue there's a blue one that's like egg crate material,
mhm,
and it's got the built-in arm folds that come around the arms. I didn't like that one when I first saw it because I
mhm.
was like, "Oh, this is too it looks too bulky, like, it's too
Yes.
much." But when you get the patient positioned on it and you tuck those under, they're just so well protected in there, and they're not going anywhere with that foam material, they're not moving. Now, I will say about the shoulder braces, some doctors insist now I've worked places where anesthesia did not allow them. I mean, I've worked in hospitals that anesthesia said, "Nope, we're not using those." I don't know if it was a certain point in time, John, that they were seeing a lot of brachial plexus injuries with
Oh,
the
wow.
trend guards, like the shoulder, stops. But I
Hmm.
work with this. Also worked with surgeons that insist on having them. So the important thing to remember with the shoulder stops again is corroboration with that anesthesia provider. You want to make
Mhm.
sure that you've got that finger width between the patient's shoulder and the pad of that trend guard or the shoulder stop, whichever kind you have. One of the key points here, I want to point out that after we've done all this positioning and you're gonna be going steep Trendelenburg, I mean, even
Mhm.
30 degrees head down is so steep,
Mhm.
is to don't be afraid to ask for a tilt test.
Oh,
Once you
thank
get
you. I
that
forgot to
patient
mention that. Yep.
once you get that patient and a lot of these patients are up in stirrups because they're
Mhm.
pelvic patients, but even, like, for inguinal hernias, they might have to go steeper head down than what we anticipate. But, yeah, doing that tilt test before we prep and drape, which means I just go ahead and have anesthesia. I want all the eyes on the patient's bed. We're gonna go ahead and put them down, 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 and see if we're gonna eyeball the patient and see if they move. So that's a very good practice to be in. Just give it a test and see if they move once you have them all in position. Another
Mhm.
thing with that pink pad, there's a soft Velcro strap that comes across the chest as
Mhm.
well. So we've got them strapped at their chest. They're
Mhm.
on the specific material pad that's not going to slip and slide, and they may or may not have the shoulder stops as well. But you're right, if they're up in
Mhm.
stirrups, you definitely wanna make sure that they're not moving. I mean, that's just
Yes.
even so this is another one of those, like
Yeah.
prone, that you need a lot of eyes on everything. You need
Mhm.
to make sure that we're looking and paying attention to those things, so
Yeah, I agree that, and I found my notes on what I'd written down, and that's surprising about the Trend Guard because this company specifically says that it won't cause any pressure against their shoulders, so you get a brachial plexus injury. And I've used it at certain institutions, I guess maybe, and it's used for patients from 440 pounds all the way up to 550 pounds that you're going to put in steep Trendelenburg with lithotomy, and it seemed to work just fine. I don't know if they maybe used the right size, pads or didn't. I'm not gonna speak about that, but
yeah, I mean, we can't
the
speculate, but I
right.
do know, and it's been a few years ago now that happened. I don't and I
Mhm.
again, it seems like I kinda heard that there had been a rash of brachial plexus
Sure.
injuries, and so anesthesia just put their foot down and said, "We're not using them." And the ones we have, I don't know if they're Trengard, I honestly don't know what brand name they
Mm.
are, but they're a C shape, they're very well padded, thick padded, and they are in a
Mhm.
C shape, so you wanna put the open part of the C towards the patient's neck,
Mhm.
so the
Right.
C is open to the patient's neck, and that's gonna avoid the pressure in that area of coming down on those shoulders, so, we
Mhm.
haven't had any problems with them, but I do currently work with a surgeon that insists on having them, and again, I've worked with surgeons that
Oh,
didn't want
okay.
them. 'em. I've worked with anesthesia that didn't want them, but
Mm.
currently, we do use them on certain procedures at the facility where I am, so
Okay, well,
just but
that's
some principles to know there with the shoulder stops too, so if you don't if
yes.
you're in a place and you don't know, you're putting those on and you've never seen them before, just don't be afraid to ask somebody to help guide you with that, and, you need those extra clamps in the room for that as well.
That's a good point, when I'm using something like that because this other hospital I was at, I'd never seen the Trend Guard before, never heard about it, And so that's what I ask. Can I get an in-service on that? And then I will look it up on my phone and I will watch their videos on their website, or I'll search YouTube for their videos
Right.
ahead of time. That's why I like to see what room I'm in the next day. Now, granted, that's where it could change at any time, but I'd like to know that so I can do this kind of stuff and do some research ahead of time on any positioning aids. And since we're talking about the trend guard, there's certain specific things you need to know about that. Like those pads have to be appropriately sized, but that metal part that goes onto the bed, the longer part should face towards their feet. And it's got very abrasive hook Velcro on it. So you want to put a towel or a pillow while the patient's moving over onto that bed. And then once they're asleep, you could take the pillow away. And then that's when you put that little neck pad that you mentioned. It's a long straight pad that's got that roll that goes under the back of their neck, and then
Mhm.
a little dish that holds their head, and that attaches to the Velcro. And then you have these size specific, some are disposable, some are not disposable pads that you put around them to keep them from, and basically the company says it keeps them from their weight shifting or the tissue shifting. It's not made as a support. And you have to make sure that also clamps to the bed. I've also double checked other people, and those things were not tightened down before they
Right.
did the tilt test. And that
Yeah.
can be a disaster because then the patient will just slide right out, which is not good. But I'm glad you brought up the tilt test. I meant to mention that and I did not. It is key to do a tilt test. I'll go as far as I can, 28, 30 degrees if I can, and make sure the patient tolerates it. Airway pressures don't go too high. There's no problems with their ventilation. And then now that I found my notes, there's a company called Allen that makes the vac pack. It's called the Hug-A-Vac, and that's what I mentioned. That's got those beans in it, or it's like a bean bag, and you just mount it up. It attaches to the bed directly, and then you mount it up around where you want to go. There's the Safety Secure Steep Trendelenberg Positioner, and it's a disposable one piece where nothing else is needed. There's no slipping or positioning of the patient. I think that's the one that you mentioned that has that blue pad that comes with the arm rolls integral to it, and then you roll it around them. And when I first saw it, I didn't like it either, but then I fell in love with it after I used it a few times
Mhm.
because it's just great. It accommodates their arms well, and they're well padded, and they're not overextending. And that's another thing you want to keep in mind when you're positioning these patients and their arms are by their side like that, that they're not hanging over and hanging free, that they're supported by the bed. But if they're too big and too wide and it looks like they're hanging, then by all means put the armboard on the bed and lay it lateral so it's facing running alongside the bed to give those arms support, because
Mm.
that's another way to get a stretch injury.
Yeah.
And it's Exodus Medical that makes the pink pad. IMP Medical makes the Trend Max, which is a big gel sheet, and it's latex free and it attaches to, I've never seen it, but that's one I saw in my research. And then Steris makes the Trend Guard. So I think that, and like I said, we're not endorsing anything. We're just giving you the information. So maybe you could use it at your institution. So that's all I got on lithotomy. Excuse me, Trendelenberg. If there's anything I missed, put it in the comments.
Yeah. Yeah, let us know.
And
Or if
now
you have
it's
any
your
tips.
turn. Your turn for
Um,
lateral
yeah,
positioning.
we go lateral now, and so lateral is going to be for, different procedures, obviously. We've done thoracic
Mhm,
cases in lateral,
mhm,
and, you could be working on something on the back, the side of the hip, a lot of things, that we can do in lateral position. So the first thing I'm gonna wonder, and when we go lateral is, are we using a bean bag or not? Are we gonna
mm,
go true lateral or modified lateral? So sometimes we call modified
mhm,
lateral lazy lateral. So
mm,
that's gonna be my number one question. And so, as the first assistant, I'm gonna go assess what we're operating on. In
mhm,
thoracic case, I've done thoracic surgeries, robotic thoracic cases. I know that's gonna be true lateral. If we're doing lobectomy or any kind of lung surgery, typically
mhm,
we're gonna be true lateral in that, and we're gonna definitely want that bean bag for those true lateral positions. So when you have the bean bag involved, you want to make sure that you've got the sheet on top of it. The patient's gonna come in and lay on the sheet, that you've got that suction tubing ready to hook up, that whatever suction canister or Neptune that you're going to use. I like to have all that ready to go. I test the bean bag and make sure it hardens with the suction, that all that's working, that I can then let the air out as needed. So I just kinda test all that beforehand. So the bean bag is gonna be that true lateral position, and, you wanna make sure that when you position that bean bag on the patient, um, that it doesn't come up and well, that it leaves the operative site open, obviously. So just that's a note to make sure that the beanbag that doesn't come up, and because it can come up as high and taco them in there, but you might not want it. So just a note, it seems like common sense, but just make sure you position the beanbag where you want it when it's soft before we put the suction on it. Some other things I'm gonna get in the room before lateral position are some pillows. Again, we wanna make sure we have plenty of gel pads or egg crate foams to put under those bony prominences. Consider what you're gonna do with that upper arm. Is it gonna come over the patient? Are you gonna rest it on a stack of pillows and blankets? I've seen that happen. There's a lateral arm board that we could attach to that side of the bed, and the arm can rest in the arm board. Just know what your surgeon expects and know what the routine is with their lateral position, I would say to that, and you can make sure that you have what you need in the room. I always have a wide roll of silk tape handy in those. Also, if we need to tape, and typically you wanna tape over the hips. I like to have either pillowcases or blue towels. I prefer the blue surgical towels because when you lay a surgical towel over the patient's hip, so to speak, or their lower legs and you put tape over it, that blue towel is not gonna have a tendency to slip like a pillowcase would. But you wanna put some padding between the tape and the patient. So this is a lot we're mentioning. So pillows, tape,
Mhm.
gel pads for bony prominence protection or foam pads for that same thing. Uh, Plenty of pillows between the legs, guys. 2 or 3 usually is enough. I like to put 1, um, across like, up at the top, like, I guess, in the crotch area. I wanna put a pillow across, and then I wanna lay 2 down lengthwise. Again, we wanna make sure that that bottom leg is bent somewhat. We wanna pad the where that lateral knee is laying on the bed, so we definitely want padding under that knee and under that ankle bone. So that bottom leg is gonna be bent, the top leg is gonna be as straight as you can get it on those pillows. So we've got the pillows resting between the legs there. Let's see. Yeah, and the arm that what they wanna do with that dependent arm, gosh, there's 3 ways. I've seen for kidney cases, John, I've seen them worked with a doctor that actually wanted the arm that would normally come up, so the contralateral arm that's up, I've seen them position that arm actually down by the patient's side, cradle it in a soft pillow, and kinda put it down where it's slightly behind the patient,
Mhm.
but kinda down by their side, but it's out of the way of the operative field of the surgical field, and that way, the arm's not in the way for the robot or for the
Mm.
laparoscopic camera. I've seen doctors that want this arm on a stack of blankets or pillows, just kinda sandwiched with the other arm. So you're gonna have an arm board down there for that dependent arm that they're laying on to support it, but also straps. You wanna piece those arm straps together however you need to put a strap around all of that, however you've got that. And obviously the specific lateral arm boards that are made to cradle the arm or to hold the arm up. You're gonna make sure if your surgeon wants that arm wrapped to the arm board, what does he want it wrapped with? An ace bandage, a Curlix. You
Mhm.
wanna be thinking about all these things. This is one of those that you might need a lot of stuff in the room. So, if you can the information that you can find out from your team, if they're familiar with the surgeon or from the surgeon himself is what's gonna be that hopefully these things are listed on the preference card, but we all know how that goes. So, you have to think for
True.
yourself, right? You can't just depend on somebody to feed you this information or for it to be written down for you. You've gotta be thinking of why we're doing what we're doing.
Mhm.
And like John has mentioned, which is so important in this episode. I thought, "Oh, this is gonna be a short episode. We're just talking about positioning," but you see, we're going on because there are
Mhm.
things that you need to think about the principles. You need to think about why we're doing what we're doing, not just, "Oh, well, she said to put pillows between their legs," or "She said to pad this." Well, you need to know what you're protecting, what nerves you're protecting, what bony
Mhm.
prominences. You need to know all these things about your patient and what they're going to be maybe susceptible to because of some medical comorbidities or previous surgeries that they've had, their age, their weight, all these things play a role in these positioning principles. So, we're not trying to make a big deal out of nothing, but we are trying to bring it to the forefront of your thought of we have to think these things through. Like there's a reason we're doing what we're doing. There is a rationale behind what we're doing. So,
Mhm.
I will say that modified or lazy lateral is typically does not need a bean bag.
Mhm.
You can use a gel roll behind the patient's back and kind of typically, again, ask your surgeon how much tilt he wants on them back. Typically, it's going to be about at a 45-degree angle. So if you think of laying completely on your side and then just kind of leaning your whole body back, just kind of tilting your whole body back, we'll put that gel roll behind their back and then go from there and position the arms and whatnot. I've got, I work with a great urologist right now that is very involved in positioning for his nephrectomies, John, and
Mhm.
he does do them robotically, but a lot of his he does hand assisted laparoscopic. So we can go in that
Mhm.
modified lateral, and he's the same, like a lot of surgeons, they want it the same way every time. So
Mhm.
you've got it down. You know what you need in the room for his positioning. So did I miss anything that
Um, well, a few things I'd like to mention is that, there's the physiological effects of a lateral position is you have increased blood flow to the dependent lung, which
Mhm.
is also underventilated because, all that weight is compressing that lung, and that could result in shunting. One thing I'm always cognizant of is a brachial plexus injury. You wanna make sure that that spine is in line with the head and that it's adequately propped up and not extended or, hyperextended in one direction, or I guess that would be flexed or overflexed in one position. And then the big pet peeve with me every time I go lateral, whether it's, for whatever procedure, is the axillary neurovascular structures and the axillary roll. It is so
Oh,
important because there
yes,
are
I forgot the
so
axle.
that's okay. That's why we do it in a
Mhm.
team and, we complement each other, but there's been quite a few times where I've seen people put the axillary roll directly in the axilla, which is not what you want. Then it's gonna compress all those structures. Ideally, it should be 2 to 3 inches below the axilla, and if it's sometimes I'm lifting up the patient and the surgeon's putting in the axillary roll. Most of the time, I'm putting the axillary roll in, so one thing I always do when they lift them up, I put it in and I say, "There it is, axillary roll 2 inches below the axilla or 3 inches below the axilla." And just a little caveat, if it's a female, I like to come in from the back because a lot of times the breast is in the way if you come in, if they lift the patient up, maybe they don't grab the breast and it's hanging in your way. You don't want to tuck the breast under like that, especially if it's, an older lady or a pendulous breast, it can get out of position. So I always come from the back of the patient and push it through. And then I make sure I reiterate it and say it out loud so everybody hears it. Axillary roll 2 to 3, whatever. I don't say 2 to 3 inches. I'll just say 2 inches below the axilla. And I feel it. I make sure it's on the rib cage and not in the axilla because that's a huge pet peeve with me because to tell on myself when I was early, I put it right in the axilla because I said axillary roll. Immediately it was caught immediately by the surgeon because he was lifting up the patient and he's like, no, it should be 2 to 3 inches below the axilla, and I never forgot it. Padding the legs is super important to prevent any injuries, and I guarantee you there's as many products out there to put between the legs for foam. Bone Foam makes one. They make one for all different kinds of things, but one thing's like you said, it's imperative to make sure that bottom leg is flexed and that the lower leg is at 90 degrees to the upper leg. So, and to pad that peroneal nerve big time because, all their weight's gonna be on that side. So some doctors like a gel roll under the thigh and one under the calf so that that knee is supported and free floating and there's no pressure on that fibular head. As long as there's no pressure on that fibular head or it's well padded, it should be fine. You shouldn't end up with a neuropraxic injury or anything, but enough straps, like you said, tape, straps. Tape's my best friend. 3-inch silk tape is my favorite for a lot of these procedures because you can secure a patient pretty well to the bed with, 3-inch tape in a lot of places. And it's important, like you said, I thought you brought up very good points. I really have nothing to add to that. I thought it was great.
Okay, and speaking too about the very, very important that I did leave out, axe roll,
Mm.
we do wanna position that if we're using the beanbag, we do wanna pay attention to where we're putting it, that we don't put it
Mhm.
too high
Exactly.
on the patient's body, right? That we do wanna allow room for A female's breast, and, B, we wanna allow room for that axe roll to fit where it needs to. So I'm so glad
Mhm.
you remembered to say that because that is one of the most important things, and, you don't always
Mhm.
need a proper gel axe
Right.
roll. You can use a rolled up blanket or
Mhm.
sheet. Not a blanket's gonna be too thick, obviously, but a
I've
rolled
seen
up
I've
sheet
seen places that try to use a blanket. I just think it
is
doesn't
too
give
thick.
enough
Yeah.
unless it's
Yeah.
really fluffy, but then I
Well,
think it compresses too much, so I don't like
right.
using that. Like you said, I like using there's a specific gel roll that's made for that, that's wonderful. I've seen places use IV bags,
The
which
gel
looks
roll is
great.
the gel roll is the best, but an IV bag,
Mhm.
if you're in a pinch, I don't even like to do that because in my opinion, the IV bag's toast after you use it for an axe roll. Like, we
It
don't need
is.
to use it.
I
We're not
usually
using
throw
it
it
for
out.
anything else, so we've just wasted it, but, hey, if you're in a pinch and you need it, you need it, and so,
Mhm.
that works, and typically, I will roll up a couple of sheets and depending on the
Mhm.
patient's size and test that. So that works. I mean,
Mhm.
it does. We want it to have a little bit of give in it. You're right, we don't want too much pressure being there. But yes, thank you for remembering to bring that up. That's one of the key positioning things we need in lateral for sure.
That's
All
true, and that's
right.
where the creativity of this job comes in. I had a
Mhm.
patient just recently, she was a very small, very frail old lady, and I could not find a gel roll that would work, whether it was an IV bag or whether I don't like I said, I don't like using rolled sheets or rolled towels or rolled blankets for that because I think it's just too rigid. What I did find was the gel cover that goes over the candy cane stirrup. I took it
Mm,
off and I doubled it up and it was the perfect size. So I doubled it up, rolled it up in a towel so it didn't move, and then put that towel inside of a pillowcase, rolled the pillowcase up and taped it so it didn't move. It was the perfect size for her. So rolled the pillowcase
nice.
up and taped it so it didn't know the principles. Then, because a patient's body habit is injury, whatever, you have to be creative. But if you need to improvise with something else, you have to be creative. But if
Right. We're gonna go into our last one that we're gonna cover on this episode is gonna be reverse Trendelenberg, which is, the opposite of Trendelenberg. So John's gonna talk which is
it's basically this, all the same things we had talked about earlier with padding all the bony prominences. But again, like I said earlier, for these cases, I always use a footboard, whether the patient's big or not. I just think it's an extra safety precaution. I've heard from other people, I've never seen it, but I've heard horror stories of when they went to put the patient up in 10 to 12 degrees of reverse Trendelenberg for a lap chole, the patient slid off the table onto the floor. I've never seen that. I've just heard stories of it. I never want it to happen to me, so I always use a footboard. And I've been places where they've said, "Oh, the doctor doesn't use a footboard." And I'm like, "Okay, that's fine. I'm gonna use one anyways if he's okay with it." So in that
Mhm.
case, you have to make sure it's padded. The patient's foot is right up against it. It's straight. It's not it's not everted or inverted. Sometimes the patient's body habitus will automatically under the weight evert their feet or rotate them out laterally. So what I do is I have them in the neutral straight position, and I'll either have the nurse hold it there or I'll hold it there, and then I have them tape it across their ankles. I'll put a piece of foam padding so it doesn't compress their legs, but that's usually enough resistance to keep their feet straight, because once they go up in that position, their body weight will keep it straight because they're basically like they're standing. And I usually try to put it on while they're going to sleep because I want the patient to position their own foot against that, and it's the most comfortable. And then another key point that I have with that is the strap. I don't want it directly over the knees. I want it like right above the patella, because that way the knee won't give and buckle and they won't collapse under their weight. So I usually take the pillow out from under their knees after they've gone to sleep because I want their knees as straight as I can get it. I mean, I don't crank it down so that, it's the strap is holding their legs straight, but I don't give it any really give for them to collapse. And then I use as many straps as I need to. Sometimes with obese patients, they have really thick thighs. Sometimes they're like what you said. I've had that happen to me too. I've never caught it at the end of a procedure, but I've felt where their leg fell off against, you know, excuse me, my body or something. Immediately the nurse goes and puts it back on the bed, but then we secure it somehow. So if they're really big and it looks like their legs are like right at the edge of the width of the table, I will just circumferentially, well, not circumferentially, but I'll go from one side of the table to the other side of the table with a safety strap or tape or both sometimes, depending how big they are. But I'll make sure that they're well padded and it's not compressing any venous return or any arterial flow to their lower extremities. And when I use the footboard, a lot of places like to use the gel cups for the heels. I make sure I use that too. Sometimes it's a trick getting the SCD hoses around there, but
Mhm.
it's easily done. But that's the key there for me is a footboard anytime you're doing reverse Trendelenberg, just like a chest strap anytime you're doing Trendelenberg position. And when I use a chest strap in Trendelenberg position, just to backtrack for a second, I always put a piece of foam across the patient's chest, especially if
Mhm.
it's a female. And I don't want it compressing right over the breast in the nipple areola complex. I want it just above their breasts. So their breasts are coming out right from under the strap. So I don't compress
Mhm.
the breast straight down, like you said, the nipple areola complex. So, and that's important if they've had breast surgery and a free nipple graft or something. I mean, it all depends. They may have a multiple surgical history and you have to take all these things to account. So,
Right. And one thing I would say to that too, that position, John, is it's fine to do a tilt test. If you have a question, if their
Mhm.
legs look wonky or their feet look wonky on that footboard, go ahead and have, once you have them secured to the bed, go ahead and have anesthesia, set them up a little bit and put
Mhm.
them in that reverse position and see what happens while you can look at their feet and legs and see what they're going to do if you have any question. So I've never really done that, but it's certainly acceptable to do that as
Mhm.
a matter of testing and looking, having the team look at everything if you have any question about how they're gonna stay in place.
Yep, exactly. I think that's about all I got. The one caveat I would like to add, though, for prone positioning, when we talked about make sure their knees are well padded, and some places have those their channels, they look like a channel. It's a gel channel and it's supposed to go on the arm board, but a lot of places will put it for the knees. So when they roll over, both knees fall into that gel channel. And that works, but I've always seen when I flipped them back that their knees are still red. One thing I found that works, and I found it at one hospital, is these Mepilex pads that they use on the floor or to send them home with the patients, but they're big. They look like a star pattern and they fit perfectly right over the knees on the tibial tubercle and the patella. It covers both. And every time I've used those and taken them off at the end of the case, there's never been a red mark on the
Mhm.
knees. So if they have them, I use them. And that's, just a little pro tip for y'all out there, but that's what I use.
Yep. Yep, that is a good tip, and I've seen those used too, and they're cool, and they do work well. John,
Mhm.
before we end the episode, I do want you to run over real quick those order of the most common nerves damaged during surgery, and we talked about that before
Oh,
we started.
exactly.
We
Yep.
should have really mentioned at the beginning of the,
We should
case,
have.
but we have a list of he has a list of most common nerves that are injured during surgery, and so this was pretty cool in order of commonality. So, go ahead,
Exactly.
John. I'm gonna
Yes,
yeah.
the most commonly injured nerve in surgery is the ulnar nerve. So you want to keep the hand and forearms supinated and well padded to avoid that. The second order would be brachial plexus. So you want to avoid shoulder braces, avoid excessive lateral rotation of the head, to either side. And you want to keep the abduction of the arms at less than 90 degrees. No, well, 90 degrees or less, excuse me. Next would be lumbosacral nerve roots. And the fourth most common nerve injury is the spinal cord. So you want to avoid severe C-spine flexion or extension. The number fifth injured nerve is the sciatic nerve. So you want to minimize time in lithotomy. That'll avoid that, and as well as move the limbs together when you're taking them in and out of lithotomy. And last but not least is the peroneal nerve. So you also want to be careful in lithotomy with that and avoid pressure on the fibular head anytime you position them in either lithotomy or laterally. So
Yep.
thanks,
That's
Kelly,
good stuff
for
we need to know.
to
So, yeah,
mention that.
we
Forgot it.
really this went longer than we expected it to, but
It
we hope that
did.
it's been informative, and we hope that it's given people some things to think about, and really, it's more complex than it seems. It really is. I mean,
Hmm.
and I know the normal public can't appreciate that, but we're looking at so many things to keep our patients safe, and
Hmm.
positioning is a huge one because, we don't wanna we're trying to help heal these patients with surgery, not cause
Hmm.
more injury, and positioning injuries can be quite common and unfortunately, and so we wanna make sure we're doing our part to
Yep.
know what we're doing, why we're doing it, and how to do it safely. So thank you, John, for all the information you brought to the
Thank
and
you.
all the
Yeah.
physiological facts and tips that you brought to us during this episode. That was great.
No, thank you,
And
Kelly.
we yeah.
Yeah, one thing I wanted to bring up is I did read some injury reports of positioning, the injuries that have occurred from positioning. One of them was a patient in lithotomy. They ended up with numb fingers afterwards, and they were a piano player, so a
Oh,
professional
boy.
piano player. So a lot of these things can be career,
Yeah.
ending injuries if they happen. And I mean, we're here to make people better. We're not here to make them worse. So that's why it's
Right.
so important to be cognizant of this stuff. And after I do something, I never have a problem if somebody wants to check it after me or question, hey, is
Right.
that supported enough?
Absolutely.
Is that padded enough? So just be open minded and humble and by all means, guys, if there's something that you know of that we didn't cover or some positioning device or anything that you guys do that's different that you like that really helps your patients, put it in the comments and,
Please, we
you
yes,
know,
we are always learning and yeah, we would love that actually if you put something in there we didn't mention or left
mhm,
out or something you've seen somewhere. That'd be great. It helps everybody that reads it. It's gonna help. So,
exactly. We're trying to foster collaboration in this profession. And, if we can put it out to everybody and it can make their practice better and makes your patients safer, then that's what we're here for. So
yeah.
But thanks, Kelly. I appreciate you bringing all that stuff up and doing what you did. And we may want to consider breaking this episode up into 2 parts.
We
So it's
might do
not an
that,
hour
yeah.
and 30
That'll be
minutes
okay to do. Yeah,
straight.
yeah.
Yeah. But either way,
Alright.
if it's too long, tell us. So, but thank you all for joining us. Don't forget to like, comment, and subscribe, and leave any comments you have that are constructive. So
Yep. We'll
you can
see you
find
next
us.
time. Yep, on the
We'll
Surgical
see you next
Assistant
time.
Podcast. Thanks for
That's
joining
right.
us.
Thank you for joining us, and don't forget to set the standard. Thank you for joining us today. We invite you to like, comment, and subscribe to our podcast. Feel free to look us up on Facebook at The Surgical Assistant Podcast. If you like, you can also email us at thesurgicalassistantpodcast@gmail.com. We look forward to seeing you on the next episode. Content of this podcast is created for surgical assistants and is educational only. It is not intended to diagnose, treat, or offer medical advice on surgical conditions. No patient-specific information is shared, and all HIPAA guidelines will be adhered to.